I wanted to spend a few minutes just to speak a little bit about what's happening within the private sector, because dyslipidemia or cardiovascular risk management, and especially the prescription of statins, is actually got very, very different in how we approach it in the public sector versus the private sector. So in the public sector, we looked at fire and forget, where your focus is being able to identify the risk and then deciding whether you're going to give them 10 milligrams of simvastatin or eventually 10 milligrams of rosuvastatin. But private sector guidelines is actually much more aligned with what's happening internationally in Europe at the moment. And there's a strong drive to what they call treat to target. And I just want to show you what it looks like. There's a lot of detail I'm not going to cover, and that you're welcome to look at the guidelines further if you're interested. So the guidelines we have in South Africa is a dyslipidemia guideline that was published in 2018 in the SMJ. And at that time, they were very much using the earlier ESC, EAS, the European guidelines. And then after 2018, there was an updated 2019 guidelines. And then we've had a short correspondence to say that we have updated our risk assessments as well as our targets to be aligned with these. And I will be presenting a little bit that those 2018 guidelines, which includes the correspondence. So the way the treat to target system works is that similar to our fire and forget, you're also going to identify your risk. But what you will then do is, depending on the cardiovascular risk for the patient, is you're going to actually set an LDL target goal. That's the LDL cholesterol level that you want to achieve. It gets really complicated and clever, but there's a nice table in the guidelines where then, depending, you're going to decide what is the level of intensity that you're going to need. So for LDL monitoring, it's not like diabetes where you will start on the lowest drug and then slowly build it up. You will actually already decide from the beginning, this patient's going to need atorvastatin 40 milligrams, and you'll build up towards there. So this is just to show you what the new targets look like. And you can see there are 4 levels of risk. I'm not going to cover the risk categories because they actually use a very different risk stratification in the ESC, EAS guidelines. But there's still this principle of low risk, moderate risk, high risk, and very high risk. The actual numbers are not too important. And the first thing to notice is that they have particular LDL goals that are related to each of these. So very important, if you have patients who are low risk, and I think that's a good principle anyway. So you might have somebody who's in their 20s. When you do your risk calculation, it's 1%, but they have an LDL of 3 or 3.5 or 4.2, which is not normal. And the question is then, well, at which point am I going to give this person a statin? But if they've got a low risk, we will only use lifestyle changes, and you do not treat the LDL cholesterol unless it's persistently over 4.9, which is when we become concerned about those familial hypercholesterolemias. So we will then continue just to monitor these people every 3 or 5 years. If you do get a point where the LDL is always increased and you are going to put them onto statins, then your LDL goal for a low risk is 3 millimoles per liter. For your moderate risks, your 3 to 15%, here you might consider a statin a little bit quicker, but still your main focus is going to be on lifestyle changes. You're going to keep an eye on that LDL cholesterol on an annual basis. And if you're concerned that, again, it's consistently staying very, very high, you might start a statin. And again, your LDL goal now is dropped a little bit to less than 2.6. For your high risks, you're actually going to have a very high tendency to actually put these people on statins. Most of them will be started on statins. And definitely if the LDL cholesterol is over 1.8, you are going to be very keen to put them on a statin. If it's under 1.8, you might still watch and wait, and you're going to monitor them regularly until you get them onto target. So in this high-risk group, you want your LDL goal to be under 1.8 millimole per liter. And if it was quite high, so in the higher LDL levels, then you actually want to see a reduction of more than 50% by that LDL cholesterol. Our very high-risk patients, so remember these are patients who's already had a stroke or a heart attack or PAD in the past. All of them get lifestyle changes, but they will all automatically get a statin without any other considerations. And again, you'll monitor them at least every 3 months while you're trying to get them onto target, and then 6 monthly when they are on target. and there's an LDL goal set of less than 1.4 millimoles per liter, and you want your LDL cholesterol reduction of more than 50%. And feel free to look at the guidelines specifically on the risk scores they use, which is very, very different, and how they stratify these. So what we want to do is, once we I've now decided what we're going to give, so this is just to show you, you might decide I want to reduce my LDL by more than 50%. I'm going to need at least atorvastatin, say 40 milligrams for that. You don't want to give them the whole 40 on the first day, just from a side effect point of view. So you might start them on 10 or 20, and within a 4-week period, you're going to build them up to that 40 milligrams. If you are on private, you'll be able to do another lipogram between 6 and 8 weeks. And in HLS, we tend to wait later, although somebody told me that you could potentially get away with it, doing it somewhere between 8 and 12 weeks. And remember, you have to do a full lipogram to then check that LDL cholesterol level. And once you're, and if it's not quite on goal, then you will adjust your statin accordingly, and you will continue to monitor until you're on target. Once your patient's at goal, you can do a lipogram annually. With your patient on statin, the EAS does monitor the ALT at baseline and at 12 weeks, but in public sector, we would only do it when it is indicated. This is the treat to target medicine sort of progressions. So the first line of treatment is your high intensity statin. So your highest dose of, you're going to build up till you get to the highest dose of statin. If your LDL cholesterol is still not on target, then you can add ezetimibe, which is one of the newer drugs, and I believe it's also available in the private sector, but we don't have it in the public sector. And then the third line, I'm actually not sure about use in South Africa at all. It has been registered here. It's expensive. It's something that you, comes as I think a subcutaneous injection. And the PCSK9 inhibitors is basically reserved for those very high-risk patients, like our familial hypercholesterolemias, or patients who've already had a stroke and a heart attack, and only when the statin and the ezetimibe has not yet brought that cholesterol under control. So that's given us a nice little brief overview. Please check out all the other tutorials that will look specifically at how you can identify your patient's risk, some of the lifestyle advice you can give and to identify who needs a statin.